Welcome you all to Grand Rounds this morning. My name is Walter Urban from the Cancer Center, and it's my pleasure to introduce this morning's speaker. Dr. Nelson and I have had the opportunity to work together for a number of past few years on joint projects in the Cancer Center where she had a part-time appointment. And it's my pleasure to welcome her here today. Heidi is a research professor and vice chair of medical informatics and clinical epidemiology and medicine, and Director of Scholarly Projects in the School of Medicine at OHSU. Dr. Nelson also serves as a consultant here. She completed her undergraduate and professional degrees at the University of Minnesota, residency in internal medicine at OHSU, and a fellowship in clinical epidemiology at UCSF. Her research, teaching, and clinical activities have focused on clinical epidemiology, screening and prevention, women's health, and healthcare policy and delivery. Dr. Nelson serves as lead investigator in the Pacific Northwest Evidence-Based Practice Center and is the collaborating principal investigator for the Health Resources and Services Administration-sponsored Women's Preventive Services Initiative. She's conducted numerous systematic reviews on screening, and if you look at the Annals of Internal Medicine every year, there's some big important paper on estrogen use or breast cancer screening that policies based on some of the great work that Dr. Nelson has done. She's also served as an investigator for several prominent national studies, including the study of osteoporotic fractures, breast cancer surveillance consortium, breast pathology study, and melanoma pathology study. She has served on influential national panels, including the Institute of Medicine Committee on Prevention Services for Women that determined services to be covered under the Affordable Care Act, Prosper Scientific Consulting Committee for the National Cancer Institute, and the NIH Advisory Committee on Research on Women's Health. And it's my pleasure to invite her here to talk to us about breast cancer screening and shared decision making, a topic that's on Twitter a lot with one of your colleagues at OHSU who gave us Grand Rounds a few weeks ago, Dr. Prasad.
Thank you. So let's see, how's the sound doing? Can you hear me? Not great. How about back there? Can you get the sound up better? Better now? Okay. I have a helper in the back there who's going to make sure we're sounding good. Fantastic. Well, you may be very tired of hearing about breast cancer screening. There's so many ways to slice and dice the information. So hopefully today we're taking a little different angle, and maybe I can show you some new things about how to actually do this shared decision making and actually work with your patients to come up with the best breast cancer screening plan for her. We have three main objectives in the next hour. First off, I'll walk you through the current breast cancer screening clinical guidelines and the coverage recommendations. I've been very involved in both of those nationally. Then a quick look at current evidence regarding screening in order to appropriately counsel women in your practices. And the goal here is not to go through every single study, but to highlight the things that are strong and the things that are weak, so that that kind of nuance can come across in a conversation with a patient. And then finally, to apply some methods of patient shared decision making to breast cancer screening decisions, we'll show you a model of a shared decision making interactive tool we created and working on implementing here at Providence. So hopefully that'll give you some new skills as you walk out the door, at least some things to think about that create more the user end of the breast cancer screening recommendations, not so much the middle part where everybody's debating about different studies and different ways of actually operationalizing them. I have no financial disclosures. All my support is federal agencies and institutes. I am the principal investigator for evidence reviews for the U.S. Preventive Services Task Force on breast cancer screening and breast cancer risk and a number of breast cancer related topics. We're starting one now on genetic testing, use of medications to reduce risk, so a number of things related to breast cancer screening and prevention. I'm also principal investigator working with the Women's Preventive Services Initiative, which is a new group of over a dozen professional organizations that focuses on preventive services for women that aren't addressed or covered by the task force recommendations. So I worked on the recommendation on breast cancer screening for coverage. So I'll show you here how these are related. Let's go through where we stand currently with guidelines and coverage recommendations. Things are always changing. So I have to kind of check in almost weekly to see where we are on some of these things. At the core of practice guidelines and insurance coverage in this day and age is evidence. And evidence is one way of describing the body of research relating to a health service, particularly focusing on the effectiveness, does it actually work, as well as the potential harms. And harms are an important part of the equation because for prevention services like screening, the person walking in the door is healthy. So the bar is high not to cause harm for someone who's walking in the door healthy. So looking at benefits and harms, the effectiveness of a service in a screening capacity, the body of evidence is at the core. The old days of people going in a room and figuring it out without evidence are long past us. The next layer, though, are practice guidelines. Guideline groups need to take that evidence and create some meaning for practitioners and patients. And guidelines often have to stretch a little bit beyond some of the evidence because, as you know, there are gaps. We very rarely have the perfect studies to answer all the questions. So in order to come up with a cohesive guideline, guideline groups have to either make assumptions or create models or use practical advice from current practice standards. There are a lot of things that inform guidelines that are outside of evidence, but evidence still has to be at the core of a good guideline. And finally, the outer bubble is coverage of insurance. Who's paying for what? And again, part of the core being evidence. In this case, insurance coverage is sometimes more generous than the guidelines because the guidelines are actually intended for a population of patients. And we all know there are individuals who need something else. So in a good case scenario, insurance coverage expands beyond the more narrow guideline. In some situations, these bubbles are exactly connecting, exactly overlapping. We have examples of that, but most of the time there are these gaps. You can see the bubbles are sort of contained within each other. They're not entirely overlapping. And that's where there's a lot of murk and confusion among patients and physicians and who's paying for what, who's interpreting what, and that's why we get into trouble trying to make sense of it all. But hopefully I can kind of show you where we stand today and how we've made sense of this sort of collectively over time. To operationalize this model, we take a look first in a more of the sequential process. We look at evidence in a way that's now operationalized. There are standards. An Institute of Medicine panel created this body of work, standards for systematic reviews, that sets a gold standard for how you actually look at evidence. So we don't just go make it up. You don't just pull out papers and try to kind of debate each other with this paper or that paper. There are standards for systematic reviews that are very rigorous and set by standards actually around the world. These standards in the IOM document are very much the way it's done at the World Health Organization and other countries around the world. So evidence must be looked at in a formal and systematic way. As the evidence is reviewed and moved on to the guideline group, they don't just go in a room and make it up either. There's now a standard, a set of standards, also a different IOM committee created clinical practice guidelines based on standards, high standards in the field, and informed by the systematic reviews that the other panel came up with. So there are standards for guideline groups. And quite honestly, even though those were established in 2011, there aren't that many groups that really adhere tightly to those standards. But two groups that do, and that are very influential in informing coverage, are the U.S. Preventive Services Task Force, which is a non-governmental panel of experts in prevention and screening, who review the evidence and come up with practice guidelines for prevention services. The guidelines that get a rating of A or B level, which is attests to the strength of evidence, are then often used to inform coverage decisions. And then the new group, the Women's Preventive Services Initiative, using similar process and adhering to the guidelines for systematic reviews and for clinical practice guidelines, they also are influential in creating policy. So the third step insurance coverage. And as you're likely familiar, the Affordable Care Act mandated that preventive services that have evidence of effectiveness are covered without copay deductibles for private and public insurance. So this affects 138 million people in the country on both types of plans. So you can see the chain of work here. Those evidence reviews ultimately work their way into informing coverage for millions of people in this country under the ACA mandate. And so it's a very important, transparent process with rigid standards. So we don't just make it up, and hopefully there's some understanding about the rigor of that and the carefulness at which that's been done. Prior to the ACA, most states in this country had statewide mandates to cover mammography screening. And so the national mandate actually unified those, so we didn't have 50 different versions of that. Had a single version based on evidence, so that cleaned it up quite a bit. But as the future of that's being debated, the possibility that defaults back to sort of state-by-state mandates is maybe the next step if that indeed happens. But it's important to see how this all connects. And it's important patients don't get it sometimes either. It's very confusing and changes. But this is where we are today, if that helps you. So the U.S. Task Force came out with an update to their breast cancer screening guideline a year ago, actually in February of last year. And the letter grades listed in the table stayed the same as in 2009 when those were made, and kind of shifted thinking a little bit. For women in their 40s, the task force gave that level of evidence a C grade. And so a C means that the benefits and harms are too close to call. They kind of even out. And so on a population level, it's difficult to recommend mass screening. But on an individual level, there may be women who would desire and need to have screening. So that's a C. That's how they define their C. For women 50 to 74, the evidence from the trials was more compelling and led to a B-level recommendation, screen every 2 years. And the interval, there's very little evidence about correct intervals. That was based on a modeling study that they commissioned. So that would be considered a weaker level of evidence, but it was the best evidence they could put together. So screening every 2 years is a B recommendation. And then for women 75 and older, again, it went to more an individual decision, but this time because these women are not enrolled in screening studies. So there are very few screening studies that included older women. So the task force is very closely aligned to the evidence and called it insufficient. But then defaulted the clinician should use an individual decision-making process. This time around in 2016, they looked at 2 other questions that are very contemporary. They reviewed all the evidence around digital breast tomosynthesis, or the 3D breast imaging, as the primary screening method, and found evidence is lacking to show benefit there. And indeed, the studies currently are quite descriptive. We don't have comparative effectiveness studies that reach that level of evidence for the task force. They also looked at the question of adjunctive screening in women who have dense breast tissue. Oregon is one of many states who now require by law that women be notified of their breast density when they get their breast mammography results. Although there's no instruction about what you do next, you just are informed and suggest that perhaps you need something more imaging-wise. But the studies to date really don't support that. And so the task force gave that an insufficient evidence ranking too. So what's important to see is not necessarily just the different letters, and in the old days that was sort of useful for clinicians. I used to carry a little pocket version of their guide around when I was in my clinic. Now there's a little more to it. Not only does it inform the ACA, but it also informs some of the quality measures that we all are paying attention to, including the HEDIS measure. So after the 2009 recommendation, which is similar to what I just showed you, HEDIS measure for mammography screening came out, and this is a measure by which America's health plans are sort of graded to see how well they perform different services. So The HEDIS measure is the percentage of women aged 50 to 74 who have had at least one mammogram for screening for breast cancer in the past 2 years. So it takes the strongest piece of evidence and operationalizes that into a quality measure. So regarding shared decision-making with your patients, certainly a discussion with women in that age group is merited, but it can be kind of a short, more focused discussion because this is a quality measure. There's unified opinion across the organizations that this is an important group to screen, and there's less question around it. Women coming in and fit this group, perhaps a shared decision-making piece is a less big piece of your practice, but always important to talk with women about the issue anyway. But that helps a lot. That's a lot of women. So what about coverage? As we said, coverage is a bigger bubble. And if we just looked at the task force recommendation, that B would only be the HEDIS measure. That would be the only thing covered under the ACA and other insurers. The Women's Preventive Services Initiative took that bigger bubble and looked at, okay, there is this target group in the middle, the age 50 to 74, but what about around the edges, where we've got the C, we've got the I? What do we do with those? So the Women's Preventive Services Initiative, just in December, made a recommendation that for coverage, mammography could be initiated no earlier than age 40, but no later than 50. So certainly anybody in that 40s range could still be covered, but that decision would, of course, be individualized in accordance to the task force. Screening mammography should occur at least biannually, but could be as frequently as annually because we know that's a weak part of the evidence. There may be individuals who need a closer watch. Screening should continue at least through age 74, a strong statement, but age alone should not be the basis to discontinue screening. There's no clear cutoff because the evidence was insufficient. So the insurance coverage allows for some thinking around the edges, which I think is the intention of the task force and really anyone looking at the data. It's not clear at the edges. So then this is the part that is more explicit. Decisions regarding when to initiate screening, how often to screen, and when to stop screening should be based on a periodic shared decision-making process that involves the women and her healthcare provider. This shared decision-making process assists women in making their informed decision and includes a discussion of benefits and harms of screening for that woman. So if she's in that C group, maybe it tips a certain way based on her story. The assessment of a woman's values and preferences, certainly that's important, and consideration of factors such as life expectancy, comorbidities, and health status. And that may be more pertinent to the women thinking about when to stop screening. What their women who are aging, who have other conditions, maybe screening is not a good idea at that point. So shared decision-making has a really big role in this insurance coverage piece, and time to do this should be covered and should be part of a clinical visit. The Women's Preventive Services Initiative didn't want to leave out women at increased risk in case in all the hands down the line, they're kind of left out of screening. They should also have periodic mammography screening. But recommendations for additional screening, which is recommended by some of the professional groups, were beyond the scope of this recommendation. So there may be a new recommendation coming up that talks about the role of MRI or other things for the high-risk women, but they should at least get periodic screening, and that should be paid for. So that just is sort of to include everybody in this coverage decision. So there's a lot of material there and a lot of detail. So the best way to do things to find this stuff nowadays are these websites. They're better than probably the printed material that you could find. And so they're easy to find. The task force has their own website with lots of, it's easy to find the breast cancer screening material. There are all kinds of reports, including our evidence review, as well as what the task force said. And there were many, many papers published a year ago on every little part of that. So lots of material you can look at if you want to. The Women's Preventive Services Initiative, we just launched a website in December and have materials up there. There's still some pieces of that being kind of finally formatted for use, but that's easy to find too, and it explains the role of that group. Both organizations allow nomination of new topics. So if there's something missing and you have a really good idea, you can submit a proposal for a new topic for them to take on. Now, if you wanted to look deep into the Affordable Care Act and see how this is all covered, I went to my usual place to find it, and this is what I got. So things are changing on the website. I think if you dig a little deeper, you might find the same page I was trying to find that tells you what's covered under the Affordable Care Act for prevention. But right now, they've changed their search engine. They're taking down some of the words, so it's a little harder. But maybe there's another way to find all that. So do guidelines and coverage decisions, do they affect what happens here in Main Street, Portland? We were interested in that question. We wanted to know if the new recommendations from the task force in 2009 and then the subsequent implementation of the Affordable Care Act roughly a year later, if they actually drove screening, which kind of outside of what happens in the clinic with you. Do these outside forces create a lot of shift that really has nothing to do with the physician and patient sitting in a room? So we did take a look at Providence data here in the Oregon region. We looked at the impact of those two things on the volume of mammography screening, and we looked at the period before, a year before the Affordable Care, or before the task force recommendations. So January, actually 2 years before they actually were implemented, January 1st, 2008 through December 31st, 2012. And then we did an interesting, I found it really cool, analysis that we borrowed from the business community. When you look at a product trending in the world, and there are all kinds of outside influences going on, including seasonal changes. If you've got like barbecues, and they're down and they're up, and so you want to correct for that over time, and you want to see if outside forces like I don't know, the price of beef or something has an effect on barbecue sales, that kind of thing. So we used that model to see if those things, the Affordable Care Act or the task force recommendations, actually change screening here. And so we broke it down by age. So here on one side you see the volume in mean mammograms per month at Providence, and the years across the bottom. And then I put little arrows, as you can see, where the task force recommendations kicked in and where the Affordable Care Act kicked in. And just to let you know, there is a yearly cycle. And for those of you in the breast screening program, kudos to you, because the spikes are Breast Cancer Month, October outreach. There's a lot of mammograms being done, and people realize I better do this before the end of my insurance year. So that's a peak that occurs every fall. And then kind of the holidays, the end of the year, after, there's always a dip. So you don't want to get misled by that. That's like the barbecues. That's like, who buys a barbecue in January, So we have to factor that in with this model. So we did take a look at the statistical changes and saw that for women in their 40s, the task force recommendations had a statistically significant effect on reducing mammography volume subsequent to that. The Affordable Care Act effect was borderline statistical significance for a mild increase, so kind of countered that a little bit, but it was not a statistically significant, but borderline. I wanted to point that out. Volumes in this group were not high compared to the other groups in general, but there was a shift away from screening once the task force recommendations discouraging, giving it a C, kicked in. For women in their 50s to 74, the group that everybody says you've got to get in and screen, there was an interesting trend. The task force recommendations didn't have a huge effect across time, but the Affordable Care Act did by increasing volume once that kicked in. So that kind of opened the doors, perhaps, for some people who had maybe financial barriers or at least perceived barriers to getting a mammogram. So that's kind of cool how that worked. For women, older women, again, the task force recommendations that said there insufficient evidence showed decreased screening among that age group. The Affordable Care Act didn't make a huge difference, and so there was that trend happening. So then we broke it down by insurance to see, well, how does that factor in? And when we look at the task force recommendations, there was a decline in screening among women with commercial insurance, and that may be partly weighted by age, because those would be more younger women, perhaps, as opposed to older women on commercial insurance. But the Affordable Care Act increased screening in all the public insurance groups. So it really did its job in kind of encouraging people maybe to come in and get screening, and also those age groups that are more focused on screening. So there were trends that way. So if we wanted to summarize all this, we could see that mammography screening decreased among women who were less than 50 and greater than 75 in association with the task force recommendations, so that went down. But it actually increased among women who were 50 to 74, mostly for the Affordable Care Act effect. And these trends actually showed increased screening efforts on the population most likely to benefit based on the evidence rating of a B for that group. So these are big drivers, and they happen outside of the clinic setting. So the whole thing you do with shared decision-making with patients, of course, very important, but there's a lot happening outside as well. And I thought that was helpful. We haven't checked what's happened since the task force recommendations and all that were kicked in last year, so we may have to update what we've got here and see what happens. So those are important things: insurance coverage, practice guidelines, the performance measures. Those are big external influences. When you actually sit down with someone in the office, it's also helpful to appreciate where the strengths of evidence are. So you can make stronger points. You can kind of soften a little where the evidence is weaker, and kind of help guide that person along. All evidence is not equal in this case. When we look at evidence, doing one of these systematic reviews for the task force, we very carefully start with defining the target population. And when I sit down and talk to radiologists or other people in the field, part of the reason there's a disconnect is that we're defining the screening, what screening is, and the screening populations differently. So the task force and their recommendation really is focusing on women who are average risk. They don't have any previous or current breast abnormalities, and they're not people who we would consider high risk. Those women have different recommendations coming from different groups. So obviously anybody with a current physical finding, the task force and prevention science in itself doesn't use screening in the way of diagnosis, but a lot of people use the terms less rigorously. So that's where we get in a lot of confusion about what is actually screening. And screening's not working up a current physical finding. Also, women with previous breast cancer or other abnormalities are more in a surveillance mode, even if they fall out of that and actually we lose them. But that's how they're considered when putting together a screening review. They're really not, they've already been defined as someone with something. Even if it's not cancer, some of these other lesions may fit that. Certainly someone identified with a BRCA deleterious mutation, very different pathway for that person. Those with strong identified family history, and that precise calculation of 15% lifetime risk can only be made with a kindred analysis, so someone who's actually gone through that and may not have an identifiable mutation, but has a strong history, family history, and would be considered high risk. Other familial cancer syndromes, and a small group of people, but important group of people who've had extensive chest radiation as a young person, particularly for treatment of Hodgkin disease or some other entities. Those are special groups that require different handling, and the task force would not consider them in the screening pool. So that's important to clear up right away when we talk about who the recommendations are for. So if you're in your clinic and you have someone in that box, the white box, there's something else you do. You don't have to go through the whole screening, shared decision-making discussion. This is different than that. So maybe that helps sort through a little checklist of things. Evidence also, as we go through it, considers the hierarchy of evidence. And the hierarchy is based on risk of bias. And so you wouldn't probably give medication to patients unless you know a randomized controlled trial that was controlled and had a low risk of bias showed it worked, right? That's also true with interventions and is true with screening interventions. So not considering the hierarchy of evidence and that the importance of a randomized controlled trial has the same rigor in screening as it does in medication is missing a point. The randomized controlled trials are really important. The problem is they are not perfect and they're aging, and large groups of people throw them out is not relevant these days. But they do have relevance, and anything below a randomized controlled trial in the hierarchy of evidence is not going to tell us the whole story about effectiveness. We may learn a lot about harms, we may learn a lot about other things, but effectiveness is likely contaminated by bias. So that's where a lot of breakdown comes into play as people start pulling out their favorite articles and they're somewhere down the hierarchy of evidence and may be too biased to answer the question relating to effectiveness. And so I think internists are pretty tuned into this because we use so many drugs and we're used to reading about drug trials. Interventions such as screening have a similar standard. And so that makes it hard to discuss when others don't appreciate the hierarchy of evidence. Evidence also considers effectiveness in real patients. This is applicability, and we rate studies based on applicability. And so this is a diagram I made showing that the point of care with a patient is at one end, and the types of research radiating out from the patient relate to how close they are to that point of care. So population laboratory research, absolutely essential, but quite distal to the actual patient encounter. Clinical trials getting a little closer to the patient, a little more relevant to what's happening at the point of care, and certainly health services research often right in that point of care. So it's important that we don't jump the line here. A lot of things that happen in laboratory research and even population research don't make it in prime time. They don't actually work. And so jumping that, trying to use studies from way out there to say it works over here has led to some disappointing outcomes that they don't actually work. So we need to go through at least part of this line of research in order to really demonstrate that it's effective in this setting. Then evidence also considers benefits and harms, and that's the balance that we make, particularly with prevention, in that we do no harm to people who are healthy. So ideally, we're doing the things on the benefits side. Everyone wants to reduce breast cancer mortality, all-cause mortality, advanced breast cancer, the suffering that occurs with treatment. Everybody wants that outcome. But in the meantime, we have to balance that with things that actually do happen. Those false positives, false negative results, all the biopsies, the issues of overdiagnosis, where individuals are given a diagnosis of something when they actually may never have come to be known with it, particularly the whole issue of diagnosing DCIS. Anxiety, distress, the pain that goes with this, and radiation exposure. People value those differently, so that's why those are discussed and evidence is collected, but that's why the shared decision-making encounter is important, because people have different values on those things, so we can't blow them off because we're interested in mortality. They're interested in mortality too, but they may have just watched somebody go through multiple biopsies and years of follow-up that actually have never resulted in a diagnosis of cancer. It's kind of a lot. So everyone's coming with a different context. Okay, so let me just highlight some of the new things that we found on our evidence review regarding benefits, and particularly looking at the first one, breast cancer mortality, which is a breast cancer-specific mortality, looking at screening versus non-screening. I did not put a slide in about all-cause mortality because none of the trials showed a difference in all-cause mortality. So we'll skip over that for interest of time. Then we'll also look at how screening may reduce advanced breast cancer. The idea is to be diagnosed early, right? So that's very important to screen and get in when you can be treated at a less toxic level of treatment. So that's an important outcome as well. So the big finding this time, we have 8, 9 trials of screening, depending how you slice certain trials up. Some present them in 2 parts, some of them combine parts. For women in their 40s, we have 9 different trials that contribute. They have different lengths of follow-up. There's only 1 trial that was done in the United States, and that was done back in the 60s. My mother was too young to qualify for that trial. So whether that relates to today or not is a good question. That's the HIP trial. The big change this round was that the age trial, you'll see kind of in the middle of this table, is a big trial that was done in England, specifically in women in their 40s, to ask the question, is screening effective in women in their 40s? And when they first reported data, they were kind of on the borderline statistical significance outcome for mortality. That looked like it might have been beneficial. But the issue was they didn't have a lot of cases. So was it a power issue, or was it really a benefit or not a benefit? It was just right on the borderline. They just published a paper before we did our meta-analysis showing 17.5 years of follow-up. And the dot just moved more to 1, meaning no difference. And the confidence intervals got shorter, meaning more power. So the age trial really showed no difference in groups. In fact, if you look at all these trials, with benefit being the side that favors screening, and harm, or at least no benefit, favoring the control, or on the other side of 1. Many lead in the direction of screening, but the confidence intervals all cross 1. No single trial shows benefit. And then when we combine them statistically, we also now cross 1. Before, when I did this in 2009, it was barely statistically significant for benefit. This time, it clearly crosses 1. So this was kind of lost in the publications, many publications that came out, but this was really a shift. And if anything, strengthens the C that the task force gave. We really don't have trial evidence of a benefit. But you can tear the trials apart and say they're not good enough, but they are what we have, and they show no benefit. They do show benefit in the older women. So there they do, the line moves, but they don't in the younger women. If we line these up in another way, if you're counseling patients and you want a different way of saying it besides showing people p-values and forest plots, which are not that easy to work through, especially in a clinic, we converted these to deaths prevented by screening, and to kind of give some idea of magnitudes. This is per 10,000 women over 10 years of screening based on the meta-analyses. And so the red line here is the 0 line. Did screening save lives? Over 10,000 women over 10 years. And of course, we just said that women in their 40s crossed 1, so it does cross 0. But at the best case scenario, it might save 3 lives based on those trials over 10 years of screening out of 10,000. Women in their 50s, perhaps 8. Women in their 60s, 21. That's kind of the best outcome. And then women in their 70 to 74, it also crossed 0 because there just weren't that many women. That was definitely a power issue. It may well be a positive finding, but it was just so underpowered. It's I've even thought of not putting it on the slide, but I want you to know that that was just not enough women to really make that meaningful. And so the magnitude of effect is small, but it is definitely significant for women above 50, and definitely leaning in the direction of benefit for women in their 40s, but it does cross the 0 effect. So now looking at advanced breast cancer, again, the trials are limited in showing us that, and we would define advanced breast cancer very differently now than just how big it is. We have so many wonderful ways of determining the severity and how advanced breast cancer is besides just how big it is, but this is what the trials gave. And for women in their 40s, again, none of the trials showed benefit for these more advanced levels, these bigger stages, or bigger sizes and stages. But for women 50 and above, the only 3 trials showed us this kind of data, but it showed a benefit. So that does reinforce the findings of mortality. So when you get alignment of different kinds of data, you get a stronger outcome, a stronger type of result. So looking at harms, and again, these women value these differently. Perhaps some are not important to some women, and some are very important to others. When we look at adverse effects, we have to look at the whole clinical pathway. Screening is just this first step. That's all that we're talking about in screening, and that's all that's paid for by the Affordable Care Act or any other coverage is that first image. Lots of things happen downstream, and lots of different stories can evolve as women work their way through the pathway. So we're kind of giving people entree to a pathway that could cause perhaps adverse effect later. We have to consider that when we look at harms. Once you have a biopsy, then you're put into a category of pathology that also leads to another pathway. So it's not just one thing that we're doing. We're kind of putting people down pathways. You have to think about all that when we're talking about harms. It's not just the anxiety of having a mammogram, it's all this other stuff too. So that's a bigger picture than maybe that's depicted in conversations on harms. So one way to look at this is to look for every cycle. If you're sitting down with a patient, how do I do this? We did an analysis based on millions of mammograms across the United States, a data set that's very useful for this kind of study, and came up with these estimates for every 1,000 women who have a screening exam, the certain kinds of outcomes they have. So for women in their 40s, 125 of them would have additional imaging. That might be the stopping point for some. Some would go on to biopsy. 16 would have biopsies. Of those, 2 would have invasive cancer, 2 would have DCIS, and out of this 1,000 women, there might be 1 missed cancer because of false negatives. You can see across the different ages it changes. The biopsies are pretty stable. More cancers are detected as the ages go up because the incidence goes up over time. The callbacks, the additional imaging goes down as women age because of breast density changes and just it's a better test as women get older. So this may be helpful when you're counseling women, particularly in the 40s and at the upper age group. What do I expect on my cycle through for screening this year? We all know you don't just go once, so other researchers have looked at sort of the cumulative effect over 10 years. If you had annual screening over 10 years or biannual, depending on how it's split out here, roughly half of women would have a callback, a false positive, over 10 years. So we know that that's not distributed evenly. There are the frequent flyers who always have to come back. And so there hasn't been a lot of research as to who are these people coming back all the time, but roughly half of women eventually come back. A new line of research that we've been involved in, and it included a lot of our Providence pathologists were in this study. We certainly appreciate that. Working with Joanne Elmore at the University of Washington, we looked at a national sample of pathologists reading breast tissue in private practice and community practices, just practicing pathologists, to see how well they agree with panels of experts and with each other on the different diagnoses of biopsies. And the unfortunate finding was that although they do well in agreement for categories of benign without atypia pathology and for invasive breast cancer, it can be pretty reliable that those diagnoses are generally agreed upon by the group of pathologists. The group in between, atypia and DCIS, for example, had differing rates of diagnostic agreement. So the problem here, of course, is if you get on one of those pathways, if you've been labeled with atypia and you're doing all these things, but really the chances that you have atypia might be less than 50% really, it kind of sets the stage for maybe more discussion with patients. If anything, patients should appreciate that these are not perhaps firm diagnoses all the time. And it's not because pathologists are just not good. It's because the murk in between is difficult, and it's hard to standardize that. So that's important too. So summary of harms, we have false positive rates are common, especially among younger women. And just if they know that, they may not get so excited when they have to come back. Being counseled about that is very important. Those cumulative false positive rates are higher with annual screening than in biannual screenings. You can imagine there are more cycles, so more chances to have a false positive rate. I didn't show you this data. A lot of descriptive studies show that women with false positive rates have increasing anxiety and distress. That's when things start to kind of unravel for them. They get very worried about that, and justifiably, especially as the further they go down their pathway. Biopsy results may be inaccurate for particularly those middle categories, and many women experience pain during mammography. Some don't care about that at all, but some don't return. So there is a wide range of what people do with that experience. So hopefully there's a few things that came out of that that'll help when you sit down with patients, but I wanted to show you some ways to actually do this that we've been working on. This is just to remind you, back in the early slides, we said shared decision making assists women in making informed decisions, and this would be particularly helpful for women on those early side and the later side of screening for age, and maybe talk about intervals. We don't have good evidence about intervals and about those two age groups, so that's where the Women's Preventive Services Initiative has said shared decision making should happen. Also, assessment of values and preferences, maybe the anxiety, the pain, those things are really not going well for one woman. Another woman doesn't care. That needs to be personalized. And then consideration of life expectancy, comorbidities, health status may be particularly important for women on the older end of the screening discussion. So most people in the room, internists, people in practice, are familiar with the Gale model. You just go online and you can throw in a few variables and get a 5-year risk of breast cancer, and that seems like a really good way to do things. I used to do that a lot. Just to kind of get started as to where people are, what ballpark risk level they're at. Well, we tore that down into an analysis to see, well, how accurate are they actually in that role of counseling people? The Gale model and other models derived from it are based on population estimates, epidemiologic data from populations. So does the model actually work when you sit down with an individual patient? Does it predict cancer? So we found 19 studies of 13 models. Most were Gale model derivatives using different variables I've listed in the slide. When we put them all together and looked at the area under the receiver operating characteristic curve, as you remember, this is a plot of true positive rate by the false positive rate, and anything kind of in the 0.8, 0.7, and above shows 70 to 80% predictability is maybe not a bad clinical tool, probably useful. Anything hovering around a 50% prediction is kind of like a coin toss. So it's essentially a worthless clinical tool. And so when we plotted out and pulled out the data regarding all those models, they kind of sat there, 0.55 to 0.66. They were just a little better than a coin toss. They really don't predict well on an individual level. And so if anything, I would sort of abandon using the Gale model in this way until we can show that it actually does a better job. So now what do we do? There are ways to approach this that don't deceive you or the individual about a certain number coming out. There are ways of working through the data that are more patient-friendly and hopefully quicker for you. So the development of patient decision aids has become a popular thing, and we've been working here in Providence to come up with some that would be helpful. A true decision aid, though, involves a patient in decision-making. It asks about personal values, it clarifies options. It's not just an information sheet. So we've been really careful here to differentiate information sheets or infographics from a decision aid. They're all designed to complement counseling from a healthcare practitioner. They're not meant to tell people what to do. So as you'd expect, we don't just make these up either. There's an international patient decision aid standard, an international group with criteria regarding decision aids. These criteria involve the level of detail, and if the level of detail is adequate for the population regarding literacy and language, whether it's unbiased and understandable. We're not going to have anything with a logo from industry or advocacy. They need to be unbiased. Clarifies the patient's values, gives them a chance to list their most important things, and provides a structured guidance without actually telling them what to do. So that's really a good decision aid. And they're hard to come by. If anything, I have to tell you there's a lack of these, particularly for mammography screening. But we developed one after the task force recommendations came out in 2009. We realized the Gale model wasn't going to work. All these little graphics people are making were either biased or had it all distilled down to one little diagram, wasn't really going to allow patients to go through all the steps. So we created an interactive aid on an iPad mini, and that directs women through and gives them choices, and they go down different pathways of decision making based on the evidence that we had just published in 2009. We developed it using focus groups and pilot tested it with women from rural primary care clinics in Oregon. And these were selected to represent a more mainstream population, unsophisticated, perhaps patient who's just trying to figure things out and work on a mini iPad and may not have access to seeing a physician as easily as here in Portland. They were evaluated for bias by stakeholders and experts, and we had several clinician experts involved from specialty clinics, primary care, many different people involved. So this was actually a study. My colleague Karen Eden was the PI. So the first thing this did was kind of what that early diagram did. We found out at the front end, we asked people about these things. Do you have any of this? And if they answered yes to any of this, they were told that they're not eligible for routine screening, but may be eligible for something more specialized for them. And depending on what their answers were, they were referred appropriately. So someone with current breast symptoms was encouraged to go see their physician and get their mammogram to work up a diagnostic symptom. Some people were referred to genetic counseling clinics. It was a quick way to triage people to the appropriate place. So that was the first thing that happened with the decision aid. The second thing was to assess familial breast cancer risk. Of all the risk factors, particularly among women in their 40s, which this was geared for, family risk is sort of the strongest factor to sort out. So we included these questions about personal breast or ovarian cancer, family members, also genetic markers. This is a short screener, a triage tool developed by the CDC to triage people to risk clinics. And so women who answered one or more questions were then triaged and referred directly. So these were done at the front end. Once you got past that, they started talking about mammography screening and about the different recommendations they've been hearing about, encouraging a shared approach, that they're empowered to discuss this and should discuss this at their next appointment. It talks about the different kinds of cancers and the risks for certain age groups. As I said, this was very focused on women in their 40s, since that's the murky area that requires sort of more information to walk through this. It used graphics to inform patients, so like the cascade graph I showed you earlier, this shows sort of what happens. 1,000 women had a mammogram. The data on this slide are a little older than the data that we just published last year, so we're updating these graphics. These different images were pilot tested with consumers, so they went through many iterations to reach this point. Then the point where they clarify their values, they're asked, what's more important for you, peace of mind or catching cancer early? And they're asked a series of these. What's the worst harm? You know, having an extra test from the false alarm, or having, not having improvement in quality of life or whatever. And those questions were also pilot tested to be patient-friendly for this demographic of women. At the end, the answers they had are summarized in a decision summary. And for some of the clinics, they were able to email that to the clinic where it was put in their chart, in their file. They could also print it out and bring it to their appointment. So even though at the end, as you see at the bottom of the page, they're able to indicate their plan, it doesn't tell them what to do. It tells them that today I'm thinking about this. They're also able to list questions. And so that was proven to be very helpful and saved a lot of time for the providers in the clinic, because people could come in with a lot of this done already. So we published that if you want to see it in closer detail, the results from 75 women. The outcomes we had, it was a short-term pilot study, so we looked at decisional conflict and showed that they felt better about their decisions, and that they thought it was very useful in preparing them to go talk to their clinicians. The clinics thought the best part was that it helped them identify women who were not the candidates for screening, and it triaged them out at the beginning. They thought that was incredibly helpful, because those women were essentially flying under the radar. They didn't know that they were at high risk. So let me wrap up a few conclusions here, and we'll have a little time for questions. Just to reinforce that current practice guidelines and coverage recommendations are based on evidence of benefits and harms. They're not made up. So often, we have a slide with all the different recommendations from different groups. They're not equal. The U.S. Task Force uses a rigorous process, and I think the new group that we're involved in on coverage decisions helps to make that more manageable in a practice sense. So the evidence can still stand where it stands, but yet coverage can go beyond that if needed. Established guidelines are used for evaluating evidence and developing those guidelines. It's not made up by anybody, and the guidelines are the standards are very clear and transparent. Evidence is weak or not available for these age groups and for screening intervals, and so they're explicitly encouraging clinicians to spend some time talking about that, and whether you can do it with a decision aid as well to save time, or to make that a more standard approach, that I think is a strong way to go, but that's not readily available, not even here yet, but hopefully we can get that for you. But it is not easy to do that. Harms vary across individuals, are very hard to predict, and so that's really the most individualized piece of this. And the shared decision making involves women in their screening decisions, and a lot of them have been thinking about this. They need to be part of that decision, and they need to do a lot of the thinking before they come in the door. Methods are lacking. We're still working on that, but hopefully we're getting a little closer. So why don't I just stop here? We will have the slides available to post, and let me just show you. I have longer list of references will be on the posted version if you wanted to look up things. So why don't I stop here, and we have a few minutes for questions. You have a question?
What are your comments about self-screening in this context?
For what? I'm sorry.
Self-screening.
Self-screening, the self-breast exam? Well, as you know, the clinical breast exam and the self-breast exam were encouraged before, but studies have shown them not to be an effective screening strategy. So most groups, including the Task Force and the American Cancer Society, recommend that patients be aware of changes. But as a screening strategy, if it's all they do, they showed in big studies in China, it leads to a lot of false positives and absolutely no benefit. But patients should be aware, and so that's still being encouraged, and clinicians should encourage, let me know if things are changing, check, it's good to check, and so that's still valuable. It's just not a mainstream screening strategy. I had patients in the old days who thought if they did that, they didn't need a mammogram. So we need to really clarify that's not the same level of care, screening is mammogram, not just an exam.
Breastfeeding and in this context?
We looked at all that. There's actually not a relationship with cancer, either for the better or worse. Many of those, we did a huge study. I think it's in the references of risk factors for women in their 40s. And we looked at everything, pet ownership, everything published. And it all came down to just a very tiny list that really held up across the studies. And the biggest one on there is family history of cancer. And so I think it's better to focus on the big guys, the big ones, and do that well than think about all these other things. It's very confusing and distracting. But you're right, that was reported. There are studies that report that, but they don't hold up. When we look at lots of studies, we try to do meta-analyses, it just falls apart. So don't worry about those things. Back there?
Thank you for your talk. It was very helpful for me. Do you try to stratify high-density breast findings on mammogram? Because those are the ones that are the cloudy areas, and whether the new imaging with gamma cameras, like molecular breast imaging, might
Right. That's certainly important. Above density. Right. Increased breast density definitely increases risk of cancer, and there are two issues of that. It's an independent risk factor, but also it makes it hard to read the mammogram, especially the heterogeneity dense, because it's a scattered pattern. And so I defer to the radiologist. If you can't see it, who am I to say don't get another study to look at that? But the idea that it's sort of an automatic formula for everybody is what the task force was discouraging. So it's open enough for clinical discretion. If a radiologist needs a better view, okay. That may not always be covered, though. The ACA is only supporting, as a mandate, mammography, the initial mammogram. There are studies happening that might change that. We need evidence to show that there's a strategy that's effective. But a lot of what happens in practice, certainly the discretion of the radiologist, they need to see it, okay. The laws make it very confusing for women, though. In this state, they get their, like many, many other states, they get their density reading with their report, and it's always unclear what to do with that. So that's an area where we have a gap right now. So I can't give you all the answers for that, but we'll hopefully have more to say next year or whatever else I come back. Great. Anything else? Yeah?
Hey, can I ask a question? I
Sure.
noticed that in the harms, you didn't include cost. And so how do you factor that in? And given your number of patients that need to be screened to benefit, what do you think the cost of a year of life saved would be, and how that fits in with what we can afford?
That's a great question. That's a really important question. The nice thing about what I do is we get to live in the cone of science and not worry about cost. And so when we do the evidence, we do the guidelines, we look at effectiveness first, and then we hand it over to Health and Human Services or HRSA. They worry about cost. So sometimes they're looking at all health services, prenatal care, all kinds of, everything. Sometimes they have to shave it back because of cost, but we never shave it back because of cost. So those groups, the operational groups, the insurance companies, they crunch the numbers, and there are a lot of studies about cost. So our job is to show what's scientifically effective or not. And it's nice to be in that cone because it can be very contaminating to think about, oh, that's expensive. It turns out some things that were expensive aren't. Look at the genetic tests. We'll talk about that another time. That's completely changed. So science first, and I'm happy to live on that side of the equation. But cost is important, and other people worry about that, at least in this chain of how we do things. Hopefully that's helpful. Any question? One more?
The BC, whatever long letter study that was done 30 years ago, showed that women who were in the screening system, more of them found the breast cancers between the mammography times. And so I would encourage women to do self-breast exam, but with all the understanding that you provided us with.
Right, right.
It's a big, significant issue.
Right, and you know what's nice, once people are in a screening pattern, they tend to be more aware, you know. The worst thing is if a patient goes and has a mammogram and thinks, oh, I'm off the hook, and a month later there's a finding and they go, oh, I just had it, I'm fine. You know, things happen fast. So, you know, our counseling is to be aware between screens, because there are those interval cancers, and those are often kind of nasty ones. So, good point. I should probably stop, but I'm happy to stay. I know you all have busy schedules. Thank you.